Yes, Professor COLLIN, yeah. Start. Yes, start.
Professor of Clinical Diabetes and Metabolism at Cardiff University. It's a pleasure to be able to present to you, and I'm sorry that I'm not present in person. So I'm going to be talking about LADA and autoimmune diabetes and type 2 diabetes, and trying again to have a look and see if these are separate diseases and also how we should manage them. So these are my disclosures. So in general, we've considered that a definition of LADA would be the diagnosis of adult onset type 1 diabetes, more than 30 years of age. They should have some evidence of autoimmunity, so the presence of islet cell autoantibodies of some kind, but importantly, not requiring insulin immediately for at least 6 months from diagnosis. In an important review by Buzzetti and colleagues in 2020, they added a few more characteristics, but these are not necessarily hard and fast. For example, a personal history of autoimmunity, suggesting more of an autoimmune process, less metabolic features, no clear cardiovascular features that distinguish it from type 2 diabetes, but they obviously needed positivity either for GADA or for one of the other islet antibodies, and of course non-insulin requiring. And they emphasize that none of these are a perfect definition of LADA. In fact, in 2020, Lohmann and colleagues talked about LADA, the idea that you could have a slow onset autoimmune disease in children, and they described 2 cases which had not needed insulin for more than 18 months after diagnosis. But I think this is very rare, and they said that in a series of 747 children, only 3% didn't need insulin for 18 months after diagnosis. So this is really an issue with adults and not with children. So here are the key questions then. Is LADA a separate endotype with a different pathogenesis, or just part of a continuum of autoimmune type 1 diabetes? Basically, slowly progressive type 1, but the same disease. And in this context, it's important to say, are some patients who actually have type 2 misclassified as autoimmune, and then they muddle up the nature of the LADA? And importantly, should LADA or adults with autoimmune disease who are progressing more slowly be managed differently? So let's start with the first question. So we do know that age determines the rate at which you lose your beta cells. This is showing progression to type 1, to needing insulin in children and adults with multiple autoantibodies, so pre-diabetes. And you can see that in the younger children, less than 6 or 6 to 11, they progress more rapidly than the teenagers and more rapidly than the adults. So we've known that for a long time, that age determines progression. So of course, LADA being in older individuals would be expected to progress more slowly. So this is the key question. Is it 2 diseases? So LADA is actually a different disease from type 1 diabetes with some overlap, and all of them are different from type 2 diabetes. Or really, is it one disease in which LADA is just the top end of the type 1 diabetes spectrum? And there's a little bit of overlap with type 2 diabetes with some features that overlap and maybe misclassification of the autoimmunity. So this is the idea here, that it's a progression of rate of progression to insulin deficiency, and LADA is the top end, the slowest end, but still part of the same disease. So what's the evidence for that? So a really important study was conducted by Anderson and colleagues in 2010, in which they looked at large cohorts, so 648 with type 2 diabetes, and we knew that they didn't need insulin for many, many years, and 213 with this idea of LADA, so they hadn't needed insulin, but they had autoimmunity. And then they also included some older type 1s, so more than 35 years of age when they were diagnosed, 257 of those, and some younger type 1s, 158 of those. And if we look at the characteristics here, you'll see how they separated the groups out. So not surprisingly, age at diagnosis was younger here in the young diagnosed at 10 years of age. But similar the LADA, similar age of diagnosis to the type 2s. If we just go down a little bit more, we look at the C-peptide. And again, as expected, because they tested this C-peptide many years after diagnosis, and you can see there's almost no detectable C-peptide in either of the 2 T1D cohorts that was required. But there is C-peptide still detectable in the LADA, but it's significantly lower than it is in type 2 diabetes. And if we look at things like BMI, LADA falls exactly in between here with an intermediate BMI, whereas the two type 1s have very similar BMIs. So one possibility for this intermediate phenotype, which is also an intermediate phenotype in things like blood pressure and in things like triglycerides, you see the triglycerides here were higher than type 1, but lower than type 2, is that it's muddled up by a group of type 2s who are put in with the LADA category because the autoimmunity is misdiagnosed. Well, one of the predictions would be that if LADA was really just a form of type 1 diabetes, there would be a continuum of genetic risk. And just to remind you, we know about genetic risk for type 1 diabetes, particularly at the HLA locus. And you can categorize them as high risk, neutral risk, or protective. And so that's what they did. They genotyped all of these individuals, and it looked like this. So here's type of diabetes over here, and here's the black is where they had the risk alleles, the risk genes, and the white is that they had the protective genes. Now, you won't be surprised, those with type 1 diabetes, almost all of them had risk genes and very few had protective genes. And it was similar in the older diagnosed type 1 diabetes. With LADA, it was a bit of a mixture here, where they had less risk and more protective, but it was still very different from type 2, which had a lot of protective and very few risk genes. However, if they separate out the LADA patients by GAD titer, you can see that those with high GAD titer, where you were definitely sure they were GAD positive, look very much more like type 1. And the middle strata looks also like type 1, whereas the low GADers look incredibly like type 2. And this begins to suggest that what's happening here is a misdiagnosis of these low GADA individuals. They're actually wrongly classified as having GADA, and they are actually type 2 diabetes. And they report there, LADA patients with high GADA concentrations were more similar, not identical to type 1, of course they were the slower progressors, but those with low GADA concentrations were more similar to type 2. So further study trying to get an algorithm for diagnosing type 1 was from the Exeter group with Lynham et al. And they studied 173 type 1s and 770 type 2s, and they were very carefully classified into the different groups as not having insulin after more than 3 years after the disease started. So these people progressed to absolute insulin deficiency, and these people did not. So here's some of the definitions here. Type 1, as I just mentioned, progressing with less than 3 years to less than 200 picomoles per liter of non-fasting C-peptide. What was interesting is when they did it this way, there was only 37 in which they were unsure what they had, and they were intermediate in the middle. So this is a relatively small group that stayed for a long time, more than 3 years, without fully progressing to insulin deficiency. But the longer you wait, the more the groups separate. And these are the kind of things they found about the two groups. So dotted line is type 2 diabetes. Of course, age of diagnosis is older, younger. BMI, of course, is smaller in the type 1s than it is in the type 2s, but obviously overlap. And genetic risk is higher in the type 1s, but again, some overlap in the population. What I want to draw your attention to is in the type 2 population, in which they had very confident that they had type 2, there was still a group of individuals who were GADA positive and some that were IA2 positive. So a small number, about 3 or 4%, that were actually positive for antibodies, even though they were confident they had type 2. They have gone on to a predictive model that you can look up on diabetes genes, and what they're really emphasizing is the importance of clinical features in making the diagnosis, and we'll explain why. So they say clinical features with biomarkers have a very high accuracy for identifying type 1 diabetes with rapid insulin requirement, particularly in European participants if you're going to use genetic risk at diagnosis. So what they did is they took clinical features, and we'll go over what those are at the minute, but they're the typical ones of younger age and lower BMI, and they produced these ROC curves. If you just use what the clinicians thought, you were pretty accurate most of the time. You were correct. It improved a bit if you added GADA into the model, and it can improve a little bit more if you added IA2. It gets a lot better actually, because having 2 antibodies is more convincing than just 1. And if you add in genetics as well, you get a little bit better. You don't really need the genetics to have good distinction between the 2. Notice that whatever you do, there is still a little bit of overlap between the 2 groups. What about these clinical features? Well, the ADA have emphasized what we think are clinical features, and you're very familiar with these. They're emphasizing the number of individuals that are misclassified. About 40% of adults are misclassified, but they do actually have true type 1 diabetes, not LADA, true type 1. And they suggest use the AABBCC categorization. So age, of course, family history of autoimmune disease is a very strong indicator of type 1. BMI, but that's not absolute. Of course, none of these are absolute. Family history and very high blood glucose is a diagnosis. That's unusual for type 2, more like type 1. And obviously, if they've been exposed to things like checkpoint inhibitors that trigger autoimmune diseases. So these are the kind of clinical criteria that you apply. Now, if we're going to make the diagnosis, should we do GADA testing or autoantibody testing in everyone, in all diabetes, to distinguish the 2? And in the GADA panel that was described by Buzzetti et al., the panel agreed that to effectively identify patients affected by LADA, all newly diagnosed type 2 diabetes patients should be screened for GADA positivity. Now, this contrasts with the Exeter group, who say that islet autoantibody testing should not be undertaken in patients who do not have clinical features of autoimmune disease. In an adult without clinical features of type 1, it is likely that a single positive antibody will actually represent a false positive result. And it's worth looking at this paper, which puts the arguments, it's quite a complicated read, but puts the arguments very clearly. I'm just going to run over those a little bit with you. So what they're arguing is that it is one disease, but some of the overlap with type 2 diabetes looking like type 1 is in fact type 2 diabetes with false positive GADA. Now, how could that happen to have a false positive result? Well, remember that any test has a normal distribution. And even if it's a really good test, and actually several years ago, we didn't have such good antibody testings, but even if it was a very good test, for example, right out here, remember 5% would be the normal cutoff, 95%. But if you had a 10 times better test that was correct 0.5%, 0.5% of all the people in the UK with type 2 diabetes, which is around 4 million people, will still have 20,000 categorized as being GADA positive. And you remember back to the Anderson data, the people who looked like type 2 were the low titers of GADA. These would be exactly the people who will be misclassified at this end of an antibody spectrum. So in the Exeter paper, what they describe is that you've got different, if you have better, worse assays, so as you get a more specific assay such as this, you're still going to have a proportion who will be misclassified. This is showing better and better assays, if you like. So they argue it this way. If you do a test where in people that you suspect have type 1 diabetes, it's going to be pretty accurate because there's only a small number that you're testing that actually don't have the disease. But if you start doing it on everybody, populations with very low prevalence, so if you do all patients with diabetes, of whom the vast majority will have type 2, then you'll begin to pick up some people with type 2 who are at the low end of the spectrum, or looked at it like this. As I mentioned, even an excellent GADA assay will misclassify a lot of people if you test everybody. But if you only test those with clinical features, you'll get it right much more of the time, and you get less of these LADA or people who actually have type 2 with mild GADA positivity. There are other ways of doing this as well. If you had 2 or more antibody positives, that's much less likely to be a misclassification. So in summary, their evidence was saying that high titer is more accurate and they behave more like type 1. We know that from Anderson. That would fit with the fact that these type 2-like LADAs are actually a misclassification. The false diagnosis rate is lower in populations with a high rate of type 1 diabetes. So in young people or in thinner people, then you get less of these misclassifications. It's not associated with other laboratory evidence. You get better discrimination with a more specific assay, and I'll just show you that. We now have a better assay for GAD, and then you get less of this misclassification. Genotype will correlate with phenotype irrespective of GAD, and that is exactly what we saw from the Anderson data, that whether they had GAD titers or not, the genotype told you much more what the disease was like. This is actually just a new, relatively new test for truncated GADA. And what you can see here is that here's truncated GADA, here's the normal full-length GADA. And of the people there, you get a proportion here who are negative for truncated GADA, but positive for full-length GADA. These are the misclassifications here. And if you looked at over here, here's full-length GADA. You get some people who are positive here, but very few that are positive for just truncated GADA. It's a more specific assay. So just to finish off as to whether we should handle and manage patients with LADA differently, particularly during their period of not requiring insulin. And this paper describes it in quite a lot of detail. And what they did is to categorize patients by fasting C-peptide into 3 groups of patients. So if they're negative, they treated them as type 2 diabetes unless you suspect that they have LADA. But because there are some people who are negative for autoantibodies. In these 3 categories, you've got the category of less than 0.3, 0.3 to 0.7, and more than 0.7. And they're saying that people with a lot of insulin over here can be treated as type 2. And they're probably the misclassifications. So if we focus on these people with relatively little fasting C-peptide, those with very low or less than 0.3 fasting, treat them with insulin. That's what you need to do. In these people with an intermediate amount, you can treat them with oral agents, but it's recommended that you check C-peptide on a 6-monthly basis, because if they're progressing, you should be more suspicious about the need for insulin here. So they say that in terms of the treatments, you can use any of these treatments, but not sulfonylureas. So DPP-4s, GLP-1s, SGLT2s, although there is a risk of ketoacidosis, but it's less in these people with a lot of insulin, or even thiazolidine diones, eventually progressing to insulin. But there's some evidence that sulfonylureas result in accelerated C-peptide loss in this group of individuals, so they're not recommended. And actually, the evidence for metformin in these individuals, especially if you haven't misclassified them, is relatively weak because their degree of insulin resistance is relatively small. And they also say you can take the EASD guidance and saying if they have high cardiovascular risk, you would treat them with the agents that support management of high cardiovascular risk. When fasting C-peptide levels are more than 0.7 nanomoles per liter, this essentially is like type 2 diabetes. And so the advice from Buzzetti et al. Was use just a slightly modified algorithm. So in other words, you would treat them as type 2 diabetes as the ADA EASD algorithm, except for the fact that you might measure C-peptide measurements. I put 6 monthly here, but we're only just checking to make sure that the C-peptide is not declining. But they do state some of these cases will have false positive autoantibodies and therefore be true type 2 diabetes. And in this group, you could also use metformin because essentially this is type 2. So with all these therapies, although they may control the HbA1c, they're not changing any autoimmune process. And in this review, they raised the idea of trying to intervene in the autoimmune process in LADA, perhaps differently from the way it would be done in type 1 diabetes, shown here in this diagram, with trying to slow the rate of loss. And that might delay the need for insulin. And that led to this study using saxagliptin and vitamin D in a large Chinese study to try and see if they could achieve that. That was vitamin D, it was 20,000 units orally daily, and metformin and insulin as at the investigator's discretion, but they couldn't use GLP-1s, SGLT2s, or sulfonylureas. And you can see from the alignment here, they had around 100 in each group. And if you look at the bottom, you can see that around 63% were on insulin. So many of these patients with LADA or considered to have LADA were not on insulin, and the daily insulin doses were quite small, about 0.3 to 0.4 units per kilo. Well, the result they reported, and it's probably best seen top right here, is the percentage change in the C-peptide level. Here in red, it's declining with the placebo, and in black, it's maintained either with saxagliptin alone or saxagliptin and vitamin D. Interesting enough, there wasn't much difference in glycated hemoglobin and some reduction in insulin use. When they tried to do a sub-analysis of that, it suggested that the people who benefited most were maybe those with the highest C-peptide at baseline. And that equates, of course, to the lowest insulin use at baseline. So maybe individuals who are more towards the type 2 end of the spectrum, or at least had more beta cell function. So in conclusion, evidence points to LADA being a continuum with type 1 diabetes rather than a separate disease. It has a lower genetic load, and where there is in fact low titer of GAD in LADA, that probably resembles and in fact is probably type 2 diabetes and a misdiagnosis with erroneously positive GAD antibodies. So it's now recommended that you don't check GADA in all diabetes, but only in those with clinical features, as in the AABBCC suggestions from the ADA, particularly younger and slimmer individuals. And they will reduce the number of false positives of people being described as LADA when in fact they have type 2. Other antibodies, rapid progression, and a low C-peptide at 3 years are also strong confirmatory tests that this is really autoimmune diabetes. If the fasting C-peptide is above 0.7 nanomoles per liter as an example, treat them as type 2, and almost certainly they are type 2, and usually those individuals will only have low titers of GADA and in fact be falsely detected as autoimmune. In terms of treatment, before they need insulin, generally suggested to avoid sulfonylureas, monitor the C-peptide 6 monthly to see if they are progressing, and you can use non-insulin therapies to control the HbA1c, but it's not disease modifying. You could try saxagliptin and vitamin D, but I think that result needs replicating. Thank you for your attention.